Welcome to Diagnostic Imaging's Weekly Scan. I'm Whitney Palmer, Senior Editor. Before we get to our featured interview this week about the benefits of using CT colonography for colon cancer screening during the pandemic, here are the most popular stories of the week. The predictive value of CT scans received a nod this week in an article published in the journal Circulation Cardiovascular Imaging. Researchers from the University of Texas Southwestern Medical Center determined that CT scans of the calcified plaque that collects in the arteries, coronary artery calcium, or CAC, can more accurately predict whether a patient will have a heart attack within 10 years versus a stroke. By examining CT scans from 7,024 patients, the team found that patients with CAC scores at or above 100 were at a twofold greater risk for heart attack than stroke. And this held true across gender and race, equally affecting Black, white, and Hispanic men and women. The team said these results could help providers decide how aggressively to treat patients who have never had a major cardiac event, but who also have other risk factors, such as high blood pressure or high cholesterol. Even though radiology overall is well into figuring out how to bounce back from the impacts the pandemic has had on its levels of imaging volume, not everyone in the industry is being equally successful. Outpatient centers, which according to industry analyses experience the most significant drops in volume, are still lagging behind hospitals in their recovery. In a study published in Academic Radiology, a team from Massachusetts General Hospital and Harvard Medical School assessed the fluctuations in imaging volume between the main hospital and 26 affiliated outpatient centers. They found during the early stages of the pandemic that while the hospital saw a 54% drop in weekly imaging volumes, the outpatient centers experienced a 64% reduction. And while more patients are returning for imaging now, the rise in volume is still uneven. The hospital has recovered 70% of its volume, but the imaging centers are pacing slightly behind with 66%. There could be several reasons for this, they said. Patients and referring providers could still be postponing elective imaging. Some affiliated imaging centers may be slower in reopening, or perhaps these postponed studies have led to higher acuity visits that must be handled in the main hospital. The team said they hope that this and future studies could play a role in creating generalizable prediction and economic recovery models that support budgetary and resource allocations decisions during future times of crisis. But reclaiming those pre-pandemic imaging levels is possible, according to a team from the University of Cincinnati. You just have to recover wisely, they said. And they shared their experience in an article in Academic Radiology. To reach their pre-pandemic levels within 10 weeks, they assembled a task force that included administrators, radiologists, technologists, and schedulers, and began tackling their imaging backlogs in early May. They collected imaging data by date, time of service, site of service, modality, and scanner used. With this information, they prioritized their patient list and scheduling and began planning for reopening some facilities. And by the end of the 10 weeks, they had recovered 102% of their overall outpatient imaging volume. As the pandemic lingers on, radiology researchers are still trying to identify the best ways to support patient management and diagnosis needs. One team of investigators from Sakarya University in Turkey shared their findings in an article published this week in Academic Radiology. They found thoracic MRI performs equivalently to thoracic CT when imaging for COVID-19 pneumonia, simultaneously limiting patients' radiation exposure. To make this determination, they examined both CT and MRI studies from 32 patients who were positive for COVID-19 pneumonia. Based on their findings and using the CT scans as a reference, the team calculated MRI sensitivity at 91.7%, specificity at 100%, positive predictive value at 100%, and negative predictive value at 95.2%. And lastly this week, Diagnostic Imaging spoke with Dr. Courtney Moreno, Associate Professor of Radiology and Imaging Sciences at the Winship Cancer Institute at Emory University School of Medicine, about the benefits of using CT colonography during the COVID-19 pandemic. This non-invasive imaging test not only offers more information for colon cancer screening, but it also facilitates better social distancing and less use of personal protective equipment, two factors that are critically important in the healthcare environment. Here's what Dr. Moreno had to say about the advantages of this test. All right, well, to jump in then, what kind of prompted you to examine or at least discuss the use of CT colonography during the pandemic? Why is this an important thing for us to pay attention to and learn about?
That's a great question. Even though we are in the midst of a pandemic, it's definitely important that people continue to get their preventative cancer screening. And there have been studies that have been published, in particular at the start of the pandemic, that screening rates had dropped precipitously by as much as 90%. And this article that we put together was the brainchild of Dr. Judy Yee, who wanted us to put out a publication letting folks know about the favorable characteristics of colonography in the current pandemic. So CTC is an excellent structural examination of the colon, and there's specific parts of the study that make it especially favorable during the current pandemic times.
To start at I guess, a elementary level with it, what during this time, what I guess are the best uses for this study? What should we be pointing people toward?
Okay, so I'll start out by saying that colon cancer screening, by whatever means is preferable to individuals out there, is the most important thing. We know that sadly, screening rates of colorectal cancer are only about 60% of the US population. And as a practicing radiologist, it makes me so sad whenever I read a scan of an individual that's come into the emergency department with abdominal pain. We scan them, we see a large colon tumor that's already spread to the liver, in some cases the lungs. And sadly, once colon cancer has reached that stage, it's really no longer curable, and 5-year survival is low, on the order of about 10 to 12%. So it's important that people get screened. And there are a lot of screening options out there. And the general idea is that whatever screening test the patient is willing to undergo is the best test for that individual. An advantage of CT colonography is that it is a structural examination of the colon, meaning that we can see the entire colon. We can identify polyps, including small polyps, and we can also identify cancers. So for folks that decide to have a CT colonography, they will get a report out that says either there are no polyps in their colon, or there is a polyp and then the specific size and location of the polyp, or in a few small number of patients, we will see masses on CT colonography. And so patients have that information, and so then they can decide as a next step, some small polyps we can just watch, or the patient may choose, depending on size, et cetera, to go on to a colonoscopy and have that polyp removed so that they've just prevented their cancer. Or if we see a larger lesion, then they could go on to a colonoscopy and have it biopsied to make the diagnosis. But the beauty of CT colonography is that for about 85% of patients, we won't see any polyps, we won't see any masses that weren't follow-up, and so those patients are done. They don't need to go on to a next step. And some institutions actually have it set up where for the minority of patients that do have a finding that warrants optical colonoscopy follow-up, they can have it done the same day as well, just to get it all taken care of for that patient. Risk of CT colonography, are really minimal. Got a little prop here. This is a catheter like this is what's inserted just a very short distance into the patient's rectum, and air is gently administered through the catheter, but you can see it's really floppy, and there's essentially no risk of perforation with a catheter like this. Patients don't need sedation, which is another advantage of CT colonography, is that patients can drive themselves to the procedure. They don't have to recruit a friend or a family member to go along with them, which further enhances social distancing. And then patients are completely awake for the entire procedure, so they can wear their mask. They can be sure that everybody around them is completely masked up because they're awake the entire time. And the procedure itself only takes about 15 minutes. So it's a short procedure, and many sites are set up so that the patients can just go directly into the CT procedure suite. They would briefly interact with the CT technologist to get set up for the exam. Then once the exam is over, they can just directly exit the facility. So minimal contact with any healthcare workers as well. So from a social distancing perspective, it's a great study. And then also, since fewer healthcare workers are involved than with some other studies, there's less PPE that's being consumed. So as that's a scarce resource, it's favorable from that perspective as well.
You touched on most of the COVID related question that I have, but in addition to that, are there other, I guess, benefits of CTC that we can experience or that patients experience specifically during the pandemic, things that I guess make it a preferable option?
Yes, that's a great question. And so, um, so comparing CTC to, so when we talk about colorectal cancer screening, there are two broad categories. There's structural examinations of the colon, meaning that you can see the entire colon, and those would be CT colonography and optical colonoscopy. And then there's stool-based tests would be the second category, and those would include things like occult blood testing, and multi-target stool DNA testing. And so if someone undergoes or decides to undergo a stool-based test, and again, any test that a patient wants to undergo is a good test for that patient. We want patients to get screened. But if they elect to undergo a stool-based test, then those are resulted out as either a positive or a negative test. And so the patient doesn't know if it's positive, well, gosh, do I have a little 6 millimeter polyp that is not going to be a cancer that I could perhaps wait a few months for the pandemic to colonoscopy to have it removed. They don't know a positive stool-based test if it means that, or it could mean a large tumor that they would want to act on immediately. So by comparison, the CT colonography gives the patient more information about exactly what's there in their colon. And so with that more information, they can make a more informed decision about what they want to do for the next step. Additionally, an advantage of CT colonography in this time is the risk of perforation, which is very, very small, essentially zero with CT colonography. Whereas with optical colonoscopy, which again, I don't want to discourage anybody from undergoing an optical colonoscopy. I want people to get screened by whatever method they prefer, but the rate of perforation with optical colonoscopy is higher. And so if someone does experience a perforation, then they would need to be hospitalized, which, as our hospitals sadly are contain a lot of patients with COVID, and resources need to be utilized for the COVID patients. It would not be a great time to have to go to the hospital for some unnecessary complication that you had from a colonoscopy. So patients would not have to worry about having a complication from the CT colonography. I mean, the patients don't need an IV for CT colonography. We're not injecting anything intravenously, so no risk of an allergic complication, no risk of a complication to any sort of sedation, because patients don't need sedation. So it's an extremely, extremely safe test that patients can undergo with the peace of mind that they can keep their mask on the whole time. They're completely awake and alert, so they can see everything that's going on around them. And then at the end of the test, they'll have really discrete information about what was found, which in vast majority of patients will be nothing, and they're done. They're good. They don't need to be screened for another 5 years. And then in the minority of patients that do have a finding, they know exactly what that finding is. So they can decide how urgently they need to get it followed up, or if it's something that can wait until hopefully we've got a vaccine or things have changed in the current pandemic environment, and they could get it followed up at that point.
Well, it sounds like the lower risk of or kind of non-existent risk of perforation, and then having that more detailed information is what really makes CTC a more beneficial or more preferable test over optical colonoscopy. Are there other benefits or advantages that we haven't talked about?
So I would say that the lack of sedation is another advantage, and I definitely don't want to come across as though I'm bad mouthing optical colonoscopy, because I mean, certainly I think it's a great test, and if people want to choose that as their screening test, whatever it takes to get people screened is fine. I just know that because of the healthcare resources that are consumed with optical colonoscopy, and risk of or concerns about exposure for the patient and for the staff that are doing the procedure, there are different rules around colonoscopy, and I'm told that it's a tougher test to get these days. But back to your question, the lack of needing sedation is important for CT colonography, an important advantage, because it means, so if you're undergoing a test like optical colonoscopy that requires sedation, then you would need to recruit somebody to go with you to that procedure. So to either drive with you or ride the bus or whatever, because they would have to accompany you home after the sedation to make sure that it's safe for you to get home, you get home safely. But with CTC, there's no sedation. So you can drive yourself, you can ride the bus, taxi, Uber, whatever you want to ride to get to the procedure, have it done, and then just exit. Also, because there's no sedation, there's no recovery time at the facility. So your time for the test is brief, 15 to 20 minutes, and then you're done. You can just go home. So you're not kind of waiting to wake up in a recovery area for an extended period of time as you are with tests that require sedation. So, I mean, I think the benefits are numerous for CT colonography. The detailed granular information that you receive, the essentially zero risk of perforation, the lack of sedation, it's just really a great procedural profile in the current pandemic.
That's fantastic. On the flip side of that, though, are there instances where CTC would not be an option that patients should pursue during this time period?
That's a great question also. So really CTC is a great test to look at anybody's colon to screen for cancer who's an average risk individual. And some of the patients that we see are patients that started initially elected to have an optical colonoscopy, but maybe they had a stricture or a very tortuous colon, and the endoscopist was unable to get their scope the entire way around to see the whole colon, and those patients get referred to us because even if a scope can't make it through a narrowing, our air that we use to distend the colon can make it through, so we can see the whole colon. So from an anatomic standpoint, really there's no one that we can't image with CT colonography. So for average risk individuals, there would be no contraindications. There are some patients that are at higher risk for colorectal cancer. So some patients with inflammatory bowel disease or for example, ulcerative colitis that are at such high risk that those patients, it's recommended that they just go straight to optical colonoscopy because they're at such a high likelihood of having an abnormality from the beginning. But the American College of Radiology puts out appropriateness criteria for different categories of patients, and really for average risk individuals, there would be no contraindication to undergoing CTC. It would really just be for folks that are at such high risk, and that would be a very small group of patients, people with underlying colonic pathology due to inflammatory bowel disease that are probably better off if they choose to go straight to an optical colonoscopy.
Okay. Well, one of the things that you did mention in the article is that CTC has been recognized for quite a while now as an effective test, but it hasn't necessarily been as widely used as the industry would have anticipated. So, what are the reasons behind why we haven't seen that widespread use kind of come to fruition?
That's a great question. Um, and I could give a very long answer. I will try to give a somewhat condensed version. I think it's multifactorial. I think one issue is insurance coverage. So despite the great clear data showing that CTC is a test, an accurate test to screen for colorectal cancer that's on the list of recommended tests from the American Cancer Society, the United States Preventive Services Task Force, despite all that, it's still currently not covered by Medicare for a screening indication. And so I think, unfortunately, that lack of Medicare coverage leads to some confusion amongst both individuals in the community as well as referring doctors in terms of not knowing if a test will be covered by insurance. So that's Medicare. But now on the other hand, as part of the Affordable Care Act of 2010, based on the grade A rating of CT colonography by the US Preventative Services Task Force, commercial insurance is mandated to cover CT colonography for a screening indication without any cost sharing by the patient. So no deductible, no copayment. So commercial insurance covers it. Medicare does not. So I think that is one barrier. We see that in our own practice, sadly. We'll have patients that their doctor has ordered CTC, and in the Medicare population, we always let those patients know that Medicare will not cover it for a screening indication. Our out-of-pocket cost currently here at my institution is $607, and some patients, upon hearing that, sadly say, gosh, I'm sorry, I just can't afford that, and they cannot undergo the exam. So I think insurance coverage is a big thing. And it used to be said that there weren't enough practices across the country that performed CT colonography, but really a lot of practices perform it now. And if patients or any individuals or potential referring doctors are out there and want to know where they could get a CT colonography done, there's a great website that's put out by the American College of Radiology. Got to give a shout out to Dr. Judy Yee, who leads the American College of Radiology's colon cancer committee, and she has done great work putting this website. It's called My CT Colonography Locator Tool, and it's free. Anybody can just Google that, My CT Colonography or My CTC Locator. It takes you to a website. You can type in your zip code, and you can see the places that perform CTC in your area. So I think we just need to do even more to get the word out there that CTC is available, because I think some folks are just not aware of that. And some of the stool-based tests that are commercial organizations, they have these huge advertising budgets. So you may have heard about the stool DNA test advertised on TV. I know I see those commercials a lot, advertised on the radio, but we don't have any sort of advertising budget to promote CTC. So it's really kind of a grassroots effort by folks, radiologists in the CTC community, trying to get the word out. And we're also constantly working on the Medicare issue as well, because I think once it's covered by Medicare, then there'll be no question that it's covered for screening indications. And we're optimistic that that will eliminate any confusion, and that will help us screen more people with CT colonography as well.
That kind of dovetails into my last question here. Given that the pandemic has presented a slew of different circumstances, within the industry, is it possible potentially that you could see some type of movement in that area where maybe Medicare will start to view this as a test that they should cover because it does have these benefits and advantages, specifically, during a time period like this?
That's a great question. And I know that people at the American College of Radiology are hard at work trying to get the Medicare coverage decision changed. It seems like the timeline on decisions like that seems to be really long, but there's so much data out there. Dr. Perry Pickard is also one of the luminaries in the field who has published great data. One of the landmark articles was put out by his group in 2003 showing that the accuracy of CTC was 96% for detection of adenomas that were a centimeter or larger in size. And in that article, the accuracy was actually even higher than optical colonoscopy, which was 87.5%. So that's one of many articles showing the great performance of CT colonography. And so, yes, hopefully soon, Medicare will revisit that decision and decide to be like the U.S. Preventative Services Task Force that looked at all the data recently and did decide that CT colonography should be on that list of the tests that are graded as an A, which again, the downside or the trickle down of that is that as part of the Affordable Care Act of 2010, it does have to be covered by commercial insurance plans, with the exception of a very small number of grandfathered plans, about 11%, that do not have to follow all of the ACA rules for procedures in general, but vast majority of commercial insurance covers screening CTC now.
Well, I appreciate this. Is there anything else about the details in the article or the benefits or importance of using CTC during a pandemic that we did not touch on that you think would be important to kind of flesh out this topic and give people a very clear understanding?
I think the main points to really try to hammer home are what we talked about the favorable procedural profile. It's a short procedure. Patients can be socially distanced. They can drive to the procedure or get themselves to the procedure on their own. They're really only around one healthcare worker for a very short period of time. I guess one point that I failed to mention is the only time that they're even within arm's length of the healthcare worker is that very brief amount of time that it takes to insert the catheter. And then after that catheter is inserted, the healthcare worker moves away, presses some buttons on the insufflator machine, and then moves to the control area for the CTC room. So for the rest of that 15 minutes, the patient is way far away from anybody. So it's a very socially distanced exam. Patients get that granular information after the exam about what was found in their colon. Again, for about 85% of patients, there'll be no need for any further testing. They'll be done until their next CTC 5 years from now. Because there is no sedation, patients can get up off the CT table and walk out the department. They don't have to linger in the department while they recover from sedation, and really see how floppy the catheter is. Essentially no risk of perforation from this, so they don't have to worry that a week later they're going to be in the hospital because they were one of the unfortunate people that got perforated during an optical colonoscopy. So I think this would be a great time for people that are not caught up with their screening to put this on their front burner and get this taken care of. Do it for themselves, do it for their families, and they can feel happy about themselves once they get it done. And most folks will have a negative result, and they should go out and get their favorite meal and take out in a socially distanced way, but to celebrate that they've done something great for their health and for their loved ones.
Excellent. All right. Well, I appreciate you taking the time to kind of walk me through this today. Thank you so much.
Oh, my pleasure. Thank you for the opportunity. Really appreciate it.
Oh, absolutely.